Thank you very much, Blair and Lena, for putting together this panel discussion. And I'll be discussing taking an appropriate history for gastroesophageal reflux disease. If we could, did I just click to advance?
Use the other advancer.
The clicker. Okay, great. None of my disclosures are pertinent to this talk. So in addressing how to take a history for reflux disease, which, as Blair's pointing out, is a very general topic, probably the best way to do so is via example. So we'll see if, good, that advances. So it's Tuesday morning, 9 o'clock. My medical assistant hands me the chart. Patient's in the room. So I'm going to walk over, go in, wash my hands, make sure she knows that I'm cleaned up from the prior patient. Introduce myself. Hi, Dr. Kevin Reavis. Good to meet you. Ms. H.R. Byrne, I understand. And you're a bank vice president, flew in from Cleveland to visit us here in Baltimore in clinic, I understand. Is that correct?
Yes, that's correct.
Well, and please turn on our mic. Well, fantastic. That is great to hear. So what I've already done is basically establish a bit of rapport, and then I'm going to obtain essentially almost just from the outset an origin of the referral. She's coming all the way from Cleveland, influential, again, bank vice president. She's obviously very educated, pretty sharp. And then we can also assess, again, the pre-visit education. Now, next we're going to want to determine kind of what the goals are of this circumstance. I don't know if she's here because she has reflux disease, or I do, but I don't know if she is of the mindset that she wants to have surgery, that she's just here for information, she doesn't want surgery, and she just wants some reassurance. So we're going to go along those lines. Now, our goals are going to be to provide an explanation and clarification of what she's here for. Again, I don't know the basis of her overall education regarding reflux, and guidance. That's what we're here for first and foremost. Really regarding the complexities of the anatomy and physiology, most patients come to me, they have no clue what the lower esophageal sphincter is. They come from all walks of life. To understand what is something that's going on in your central abdomen, close to your spine, is a really hard concept to understand. So we have to address the anatomy and physiology and also instill confidence in our patients in their decision making. From the outset, I know that based on the various talks earlier today, that we have at least 6+ interventional options that we can provide for these patients. So oftentimes they're blown away and overwhelmed with the various options. Some of them are well-read, some of them are not. So we're going to have to get all that teased out. So there's a tremendous value in the personal interaction with our patients. So you have your simple and your not so simple patients. I reviewed her chart ahead of time. I've been able to look at all the objective studies that she's undertaken, and I know that hopefully she's going to be a great surgical candidate with an abnormal 24-hour pH test, which this patient has. Very typical symptoms. It says right here she has heartburn and regurgitation, and that she's been on medication. She's responded really well. So this is going to be really easy. Bada bing, going to walk in, we're going to talk a couple of minutes, and then we're going to make a decision, and on we go. So with that in mind, Ms. H.R. Byrne, I've reviewed your records pretty comprehensively now, but I want to understand in your own words. Tell me what your symptoms are like.
Well, first of all, I'm bloated all the time. My stomach feels terrible. Sometimes I have chest pain. My ears ring. My throat's sore. I feel absolutely miserable all the time. I've been to like 5 different doctors. The cardiologist tells me there's nothing wrong with my heart. And the ENTs swear up and down that it's reflux. I've been to all these gastroenterologists who tell me that everything looks just fine. And Dr. Job said that you will fix me, that you are the expert in this field.
Great. So Dr. Job. So your referring physician said that I was going to fix you. Okay. So now what really probably took place in that interaction between Ms. H.R. Byrne and hypothetical Dr. Job was one of 3 scenarios. Dr. Job may have thought, this patient definitely has reflux disease. I know just the doctor to send her to is going to be pretty straightforward, even though she's not very straightforward. Number 2, this patient absolutely does not have reflux disease, and I cannot convince her of that otherwise. I've sent her to every doctor in town. I have no idea what else to do. I'm going to send her to the only doctor I trust who can just talk sense into this individual. And then number 3, oh my gosh, Ms. H.R. Byrne is driving me absolutely crazy, and I need a good colleague who will share the love. So who will that be? Dr. Reavis. So I'm sitting her there. So any of those circumstances could happen. Rarely have I ever met a colleague who said, yeah, I totally told the patient you're going to fix them. It's usually somewhere obviously in between. So take it with a grain of salt. We have patients who come visit with us, complete a really comprehensive questionnaire ahead of time. It's about 8 pages. It's an amalgam of multiple different quality of life surveys, HRQL and FSQ. This is just a sample of one of the questions. And the whole point of this, as we pointed out in the 2 prior lectures, is patient selection is key, and you really need to be able to dice out what is real and what is potentially unrelated or even potentially life-threatening and not related to reflux disease. So we have patients obviously prioritize, what is your first symptom? In this circumstance, it's bloat. May have absolutely nothing to do with what we can actually fix with an anti-reflux operation. And then we have them go through heartburn, difficulty swallowing, regurgitation, chest pain, cough, nausea. These are all potential signs of other type of illnesses, plus minus reflux at all. And of course, we want to have a chronological baseline. Is this something that's been around for a couple of months or decades or whatnot? We go on to, again, go with associative symptoms. Is this something that happens postprandially? We typically think that reflux disease is a postprandial type of disease in the first couple of hours. Is associated with particular types of foods or medications or times of the day, days of the week, that type of thing. And then we go on to secondary symptoms as well. Regurgitation, not only whether you have it or not, but the severity, the mild, severe, times of, again, the day, and even the quality, whether it's acid or bitter or a combination or food. Again, if you're regurgitating, no bile, no acid, and a lot of food, it's not reflux disease most likely. We're probably dealing with more of an obstructive type situation. And then on the first page, this is actually just a sample shot of our electronic medical record. And we'll kind of zoom in on the specifics here. We go after your classics, your heartburn, regurgitation, dysphagia. But again, chest pain. She could be having an acute MI in the clinic. As well as shortness of breath. We could have pulmonary disease, primary or secondary. Again, extraesophageal or laryngopharyngeal symptoms, which could be everything from allergies to anxiety to postnasal drip, sinusitis, you name it. Nausea, emesis, potential gastroparesis or other type of issues. So we kind of conclude that questionnaire with, again, defining kind of why you're here. Is it because, some things are fairly mild? My reflux medication causes me to experience significant side effects, and I really want to get away from those medications, all the way down to my GI symptoms are so bad that I can't go to work. Once we're impacting the workforce, now we're dealing with a pretty substantial problem. Whether it's reflux disease or not, let's get to the bottom of it and help this patient out. So we, of course, then need to go through their objective test and just kind of lift it off to the left. Includes things like their endoscopy, their upper GI, and patients with bloat or nausea, like Ms. H.R. Byrne here, smart pill study or gastric emptying study, depending. Motility testing, and of course, pH testing as well. I'm shocked at the number, not shocked, I expect it now. The number of patients that I say, you've been through all these tests, and I know they were fun. Has anyone gone over the results with you? Most of the time, the answer is no, and I have no idea what the results are, and that motility test is awful. Don't make me go through that again. And I say, your tests were not in vain, because I have a lot of information to share with you. It's going to guide today's conversation. Let's go through it step by step by step. And it really gives them a sense of ownership and also understanding of what's going on, particularly the topography of the motility testing. Patients with a very low level of education can understand what looks like, a weather map in terms of pressure and where their esophagus is. So I find that to be very rewarding with them. Physical exam, seriously? Physical exam for reflux disease? Well, yes, of course. Body habitus and abdominal hostility certainly are going to impact our decision making. So if someone comes into my clinic who's svelte, like Ms. H.R. Byrne, that's going to have a certain initial thought in terms of, okay, here are various surgical options and medical options. If someone comes in a little more portly, then as was mentioned in the prior talk, we really need to entertain other type of options, because in terms of durability, we can do an operation to stop the reflux for the next year for sure. But if we want to do something that's going to be long lasting, 10, 15, 30 years, we really need to make sure it's someone who's not going to have intra-abdominal pressure that's going to result in failure and recurrent disease over time. And that's where, again, other discussions take place. And someone who says, I think I had a surgery at some point, but I don't really remember if it was significant. And then, they present with this type of abdomen, and I realize, now how bad are those symptoms? How bad do you want this fixed? Because we oftentimes will quote discussions we've had with senior mentors and along the lines of, you can swallow now, and you can eat and drink and poop and pee now, we could potentially change that, and not for the better. Again, given the hostility of the situation, we could potentially fix it, but the cost may be worse than the benefit. So. Also, the stethoscope, it's, yes, classic. It's always fun to see a surgeon in an ad with a stethoscope around their neck because we so rarely use them, at least in theory. But it's valuable in this circumstance. Again, they've come to you. Why don't we check out and find out if they've got pulmonary disease, if they have chest pain, you find out that they've got severe mitral regurg, et cetera. There's plenty of thoracic findings that we can determine on physical exam that will alter our discussion and potentially even come up with new diagnoses. And it gives me a chance to explain to a patient when they say, can you do it with a laser? And I explain, well, sure. I'm going to be using 5 little incisions, 2 the size of my thumb, 3 the size of my index fingernail, if we do this laparoscopically. Of course, endoscopic is an option as well. But I'm able to explain to them and their loved ones what their scars will most likely look like or what their incisions will most likely look like. And it gives them an expectation is, okay, that's pretty cool. Because my grandmother had it, and she has this giant incision from her subxiphoid down to her pubis. And so that obviously is an option that we can explain to them during that time. So all of this really is to boil down, again, decipher through everything that's kind of mentioned here. Laryngopharyngeal reflux symptoms, postnasal drip, and everything from, again, sinusitis, allergies. Eosinophilic esophagitis can present with severe heartburn, but potentially a normal or abnormal pH test, partially responsive to medication. But obviously, you may want to get that clarified before we're offering anti-reflux surgery. Functional dyspepsia and peptic gastritis. So there's plenty of patients who come and say, I have the worst reflux disease ever. I have a sour stomach. I have indigestion. My tummy hurts. And so we have to explain to them, we can cap your stomach so that you're not refluxing at all, and your symptoms may not change one bit. And I can institute some bloating and some dumping syndrome. So really being able to decipher that is key as well. Patients who have severe regurgitation, but again, pH negative, and obviously it would most likely be seen on upper GI, could be presenting with a gastric outlet, an esophagogastric outlet obstruction, which we're going to treat completely differently than for classic reflux disease. And then patients with terrible motility, scleroderma, we're going to have to set their expectations quite a bit lower than those who've got normal motility and otherwise intact GI physiology. And of course, we don't want to overlook gastroparesis and do an anti-reflux operation only to turn their stomach into basically a closed vessel where their bloat is going to be absolutely incapacitating. And then finally, the killers. You could potentially have cardiac disease sitting in front of you, as well as pulmonary issues, and even gallstone issues, acute cholecystitis mimicking reflux symptoms, and that needs to be flushed out. And then finally, constipation. That is the harbinger of just evil. Typically, we'll have patients who have the worst heartburn in the world. Their constipation is improved, boom, heartburn's gone. It's amazing how a blockage at the bottom of the pipe will affect everything all the way up. So we want to obviously address those. So our goals have been accomplished. We've been through our clinical visit, we've reviewed all the tests, and we've come to an understanding. So we've been able to provide explanation, clarification, and guidance. And she's going to be confident with the decision making that we're going to make. And I'm going to achieve a satisfaction by matching her expectations with the objective predictors of success that we've mentioned before. So, okay, let's put together our plan of action. What I'd like to do is, I think you've got a couple of herbs that you've been utilizing at home, and a couple of over-the-counter type of things that seem to be modifying your symptoms to a small degree. I want you to take a very careful recording diary over the next 30 days. Every minute that you have symptoms, you're going to write it down. And then next month, we're going to do a phone consultation where you can go back and revisit this. And I think we'll be able to put together a concrete long-term plan. And I would have been able to follow up with Dr. Jobe as well. So.
Thank you so much, Dr. Reavis.
So, great. Thank you.
Make me all better.